So 82, back to 82. And when I graduated, I thought dentistry was extremely boring. Basically, when I finished school, I extracted one tooth, I placed one composite filling, and I did one endodontic treatment, and for the rest, I watched people doing dentistry. So in 1982, basically, I was doing this. When I finished university, I was playing soccer, and I have one extract from Sports Show in Belgium. Have a look now. It's very slow, the football, and dentistry also was very slow. It's different than now. Different possibilities. Now look, that's me. So, but no dentistry. And basically what happened is I asked the manager of my club. We were playing, we were at the club every day. I asked him, please, can you send me to the best dentist in Brussels because I want to see what they are doing since I didn't learn anything at school. So they pushed me in the hands of the dentist that was treating the king, very famous guy in Belgium. And still when I was looking what they were doing, I was like disappointed because it was not what I had in my mind about how, let's say, aesthetics, a minimum of aesthetics should look like. So again, very disappointed. Then in 1985, and you have to see the context because 1985 was the first mobile phone in a car. We didn't have computers in 1980, 1982. If I was very lucky, I could go to Dr. Kirchhoff's in Stuttgart from time to time, take some information back home, and that's what we did. Today you have all the possibilities, you have the digital world, you have everything. So for a young dentist, I think it's really a fantastic moment. So at 1985, what disturbed me a lot was that I saw these dentists placing crowns that I wouldn't ever dream anymore of placing today or even 20 years ago. Too long, too fat, too much of everything. And basically what I found very interesting is how did he get away with this? He got away with everything. And today, again, the patient, the breed, the type of patients we are treating today is completely different. So, the context, again, this is what I'm going to talk about. And what I thought is maybe it's interesting to show you in 2 clinical cases what we are doing today. And a lot changed. And I am doing plastic periodontal surgery and implants since 1984, 1985, let's say. So a long time. What has changed dramatically for me is the planning. To be able to visualize your plan before you start the treatment and try to get all the members of the team together, trying to get some, let's say, concepts that we were using since 30, 40 years into the digital world. And I think that's important to understand before I will show you the cases. I want to show you 2 cases. One case is full upper lower on natural teeth, because I still think that you need to understand what's happening around natural teeth. And if you understand what you do around natural teeth, it will be easier to work around implants, in my opinion. And the second case is a full arch or a full mouth case on implants. And using the dental technology, the digital technology, digital dental technology, just to explain you all of this. So let me try to explain you what happened for me the last 15 years. 15 years ago, I met a very bright young guy in Timișoara, Romania. You would say Romania 15 years ago was like a communist country. Completely different than the world we are living in, but what I saw and thought was they are doing different things. They are much faster than we are. They are willing to work a lot, and they are willing to adopt technologies in their daily workflow. So that guy was Florin Coffard, and I'm still working. I just came back from Timișoara just to understand what they are doing, because what is happening today is it's going very, very fast. And if you are able to implement, let's say, the digital workflow and get it as a, let's say, add-on on your concepts of today, I think there's no reason not to succeed. I think that's the lesson that I took. For the first case, I want you to look at it from a different point of view. What happened before? Whenever we had a plastic periodontal surgery to do, like a recession coverage or a grafting procedure, it would always, or mostly, in most of the cases, be like you do a prep or whatever, make a provisional bridge, do the soft tissue correction, and after the healing, you would go back and eventually add a little bit of flow, change the contours. So it was a lot of work. And basically, we were always compensating prosthetically for the little details that were a little bit off in the case. Today, it's different. Today, we are doing the opposite. Whenever we have a plan, whenever we have a final form for a tooth, for a crown, we will just adapt the surgery to the crown. And if you think about it, if you have a provisional crown, it's either it will be PMMA, either it will be composite. Soft tissue will never heal around composite or PMMA as it heals around porcelain. So we need to rethink. And today we are doing a lot of things simultaneously. So most of the time we spend in the planning. And we have the tools today, and I will show you the SmileCloud, this software application that Florine developed. The new version 3DNA really allows you to visualize everything from the start. So most of the time we don't even touch the patient. We have a very clear plan. We visualize everything on the software and then we go ahead. But let me show you the case. This was a case that I treated basically 22 years ago. It was one of my friends, a lady. I placed veneers on the 4 incisors. They're quite okay after 22 years. But now she comes back and she wants me to do the full mouth and at the same time treat the soft tissue recessions. So that's the starting point. So then my question to you is, how are you going to work? How are you going to visualize what you're going to do? I think what is important to understand is that today we are relating most of these cases to the face, and it's nothing new. It's something we are doing since 25 years or 20 years, let's say. And I need also you to think about 1982, I think Dr. Kish will remember, and I remember your office was full of slides. You had a room like only slides. Imagine you take a picture. I took a picture, he took a picture. You go to the Photoshop, you ask the guy to develop, you have a diapositivo, and that's the only thing you could do. Today you have all these possibilities with the digital cameras and stuff, video cameras, a lot of things that you can do. So this is the case. It's if you are a periodontist, you understand it's a very tricky case because there is old composites, there is recessions, there is old restorations. So what's your plan? What is your incisal edge position you want to have for the 2 central incisors? Because most of the time it starts there. What is your plan for the soft tissue? What is your plan for the old composites? So it's not as easy as you think the case would be at the start. So what does the software allow me to do today? Today in SmileCloud, I can just select a picture of the face, select a picture intraorally eventually, and the algorithm will choose forms that are determined by the prosthetic space. What is prosthetic space? It's like with old full edentulous cases where you establish your incisal edge position of the 2 centrals, you establish your gingival line, and the algorithm will choose tooth forms according to the frame that you propose to the software, which means papilla height, gingival scallop, all these things are in there. So then you have the possibility to choose different forms, and you can get these forms into the face of the patient, and you can visualize it for yourself. Whatever you do on the model, you will see it in the face of the patient. In the end of the day, you are able to propose something to the patient. And this is what we are doing today most of the time. And I explain you why. Because all of these mock-up, let's say, procedures, most of the time they will not really work because most of the cases in your office, like in my office, are not purely additive cases. Most of the time they are resective cases also. So let me show you what happens. So then I go to the software, so I selected the forms. We are able to import the upper model. It gets aligned in the algorithm in the face. You import the lower model. I have to go back one. Yep. So you import the model. Everything is stacked. All the data are stacked in one central software, in one central file. and you get them just in the face of the patient. You add, it's a little bit slow now on the screen, but it's very, very visual. You add the lower, since you scan the bite, it automatically aligns it. Then you take the CBCT, the software transforms the CBCT into an STL file, which allows you to get a segmented model. Segmentation for me in implant dentistry, for example, is very important, because then I see where the roots are and where I can eventually place my implant immediately, getting some primary stability. Is a little bit different. So this is the segmentation done. You have the roots coming from the CBCT. So now you have 3 layers. You have soft tissue, you have bone, and you have the roots. And you have your future forms and the old forms. Okay, so it does really a lot. Then you will say, okay, I need to treat the full upper, full lower, and then you are stacking, the software is stacking the models. It's stacking the layers, and you're able to explain to the patient now what you're gonna try to do. So whenever you click on a tooth, you will be able to move the tooth 3D in the exact position. What is the exact position if you want a crown or a veneer? The exact position is adapted to the root, because at some point your veneer or your crown needs to come back to the root. What is the issue with the mock-ups? The mock-ups are always, or most of the time, outside of this perimeter. So we can do a lot with this software, and at the same time I'm able now to crown lengthen in the software whenever I want and where I want, and I'm able to bring the tissue down wherever I want. Where do I want to bring the tissue up and down? According, of course, of the form that you selected at the start. So if you select the form and you position it, you will be able to relate it to soft tissue, bone, and root. Okay? And this is important to understand, because in implant dentistry, it's even a more fragile, let's say, pattern of thinking. So I'm able to do all of this in one shot. I didn't even touch the patient yet. Lower jaw, exactly the same. So you know, and you can click on the tooth. You have a section. In the section, you see the future tooth, the existing tooth, the bone, the soft tissue, and you can measure how much you need to cover the root, how thick the graft needs to be, that needs to go in. And this has an impact on the treatment, no? Motion, you can add motion. In our office and in Timișoara office, they're using Mojo. Probably there's many other systems on the market by now. I have no idea, but you can add motion also. So everything is planned in advance, and I can explain to the patient. I can show everything in the face of the patient, with the patient next to me and the computer screen. If I change something on the model, she will see the impact in the face immediately. So let's go to the clinical now. And I want to explain you why we don't do mock-ups anymore. Because in this case, which is one of the older cases, but still it's relevant, we were doing a mock-up. So it's on top of the existing teeth. Whenever we do this on top of the existing teeth and we want to shorten the future position of the edge compared to the old one, you will need to mask it for the picture, no? So you're masking it with a blue pencil, and we need to add pink composite. Why the pink composite? Because if you don't add the pink composite and your tooth is out of the boundary, let's say of the boundary of the existing root and the soft tissue, take a picture of the face, patient smiles, and there's dark interfaces everywhere. So you need also to compensate with the volume of the soft tissue, and that's what we are doing with the pink composite. At the same time, we bring volume in the soft tissue, and at the same time, you're going to cover the recessions visually. How long do you think this takes in the mouth of the patient? Like 2 hours? So a lot of work for very little return. So today we are just doing it on the computer screen, except in purely additive cases. But this is only 2% of all the cases in your office and in my office. So this is a lot of work. You can take pictures, then show the patient, put a black pencil. You see, here is the black pencil. So where the existing tooth was longer than the new form, you mask it, just it's a trompe-l'œil in French, with a black pencil. Okay, then we know we need to crown lengthen the two centrals. How are you gonna crown lengthen with your scalpel 1 millimeter and create the exact profile to match the future veneer on the tooth? It's like when we were placing implants free-handed. If you're very experienced, maybe 80% will be okay. Prosthetically okay. But in this case, if we want to crown lengthen the two centrals, and we will need to, maybe it's better to create a guide. It's easy to create in Exocad the guide that will guide you doing the crown lengthening. And we're going to do simultaneous treatment, which means we're going to crown lengthen, do the crown lengthening with the electrosurge, do the bony correction if necessary, make the final preps. 2 days later, veneers are ready, bond the veneers, and the grafting will be done after bonding the veneers. So everything is guided. They're always talking about guided implant dentistry, but many other things in dentistry, because of the digital, can be guided. So let me show you what we are doing. Crown lengthening with the guide, and it's a dual guide. What you see here in the window is the future form that you want to have exactly in the 3D position that you want to have it. So you crown lengthen. It's a minimal thing. It's just creating the zenith. How do you want to do it with a scalpel free-handed? And what I learned now today is we went back to all our cases, and I started doing crown lengthening like in 85, 86. Started to document some of them. What you see is if you do whatever case you do with open flap surgery, and we were doing 100% of them open flap surgery, you are transforming triangular tooth forms into square tooth forms or rectangular tooth forms. So if you want to do these little things and do it flapless, you need to guide your hand or the instrument. That is important. We think it's important. So let me show you what happens in reality, because we videotaped everything. This little thing, very difficult to do free-handed. So what am I doing? I'm using the electrosurge. Where are you mostly changing the form or small details that you change between the line angles? Whenever you go beside of or outside of the line angles, you're changing from triangular to rectangular form. So we are doing this. Then you go for the osseous, and the osseous correction again is exactly between the line angles there. I don't want to make it less triangular than the tooth form that I choose. So it's minimal, it's details. And in the end, what we found out is when to do closed and when to do open flap. Open flap is only when your papilla volume, the volume of the papilla, is outside of the line angle of the tooth or the future restoration. Whenever your papilla is inside, you don't need to do open flap. There's going to be very little rebound. So, second thing we do, just take a pencil and mark the prep, because the prep is again related to the future tooth form. So we are prepping on the line. That's what we do. And the prep again is related to the final tooth form, and I will explain you how we prep. Basically, I took this friend of mine to Timișoara, to Romania. We started on Monday morning, and the case was finished, bonded with all the final restorations on Friday afternoon. I am not saying you have to do it like this, but what I try to explain is, if you rethink your procedures and the sequencing of the perio-pros, probably you will be more predictable and faster in the work. So we are prepping on both sides, and it's guided. It's a dual guide. My guide is used for the crown lengthening, and it's detailed crown lengthening, and at the same time it's used for the prep. How do you think with your brain can adapt to the form that you choose on the computer screen or a form from a wax up? No, it's very, very difficult to program your brain to prep exactly where it should be. So what is the consequence? Normally you would graft first and then probably overgraft a little bit, and then you will push back. So it's a lot of work. So today it changed a little bit. So what we do most of the time is, okay, there's a few things, and you can already see them in advance because you know if you look at an STL, you look differently at a case than if you go intraoral. So you look at angles, you look at root prominence. And there's one thing we learned very fast. On the canine, for example, on one side, it's too much out of the boundary of the soft tissue and the bone. So you prep your chamfer a little bit deeper, and then from the chamfer on to the bone, you push a little bit with the instrument, you're going to flatten the root. And there's one article we found, Pat Allen found this article. It's from a certain Mr. Morris in 1958. 58 is a long time ago. We don't need to reinvent the wheel, because the guy said if there's too much pressure, tissue will go up. If there's less pressure, tissue will come down. So nothing new under the sun. Guided prep, how does it work now? We prep in 3 stages. The first prep is a rough prep, which will be related to the final tooth form. So it's rough. Then you scan. It's 5 seconds to scan a full arch. In SmileCloud, you superimpose the STL in the review tool, and you can see exactly where you need to prep. There's like this color scale where you can see how much you need to prep where. The second prep will be more detailed, and the third prep will be only the margin, refining the margin. You see, you know where you need to prep more or less. Because if in the end you're going to work with monolithic restorations, which we do today all the time, you're going to have an equal thickness all over the restoration. How do you want to have this 0.8? Only by looking at it. So now you have a reference. You have the final form, you have the existing prep, the existing situation, and the preps. There's 2 or 3 preps in between, 2 or 3 scans in between, and you just relate them one to the other. You measure, that's it. Very fast and very predictable. So that's the final preps. Look at where the canine was prepped. We flattened the root a little bit, because we know from many years that it's much easier for example, to graft connective tissue on a concavity or on a less prominent root. So all of this you visualize in advance. Then something interesting, because I can tell you I've been working with the best technicians from Brazil, for example, from Europe, many of them, and getting unbelievable results. What I think today is that if I have one central or unilaterally 2 or 3 teeth to change, feldspathic still has the best optical properties. But if we are talking about full arch, maybe form and texture are more important, much more. When I had the Brazilians flying in for 2 weeks, for example, Friday evening, they were so tired that the results Friday evening were not the ones from the first day they flew in. This machine mills me the same, and coming from form of a natural library, which means there's like over 2,000 forms in there, and it's just copying nature. What does a very nice and good technician want to do? He wants to copy nature. So we are only today milling, staining. That's it. That's a discussion, that's a very difficult discussion. Because with my best technicians, many times I'm discussing with them and they say, yeah, but let's cut back a little bit and just do a minimal layering. But if you layer minimally, you're messing up the form again and the texture. So what are you going to do? Let me show you what we do. So these are the restorations. 2 days later, we do like you should do probably. It's not only about bond strength. There's this study from Rui Felaccio where they see you have better bond strengths. But it's also the let's say more like the comfort of bonding a full arch. I did all the surgeries in this case. Florin and his colleague did the preps. The bonding they do 2 dentists together. One is left-handed, one is right-handed. They sit each on one side, an assistant, another assistant, and one in the back to bring the materials. In 1.5 hours, you bond an arch like this. You start with the 2 centrals. There's like protocols. Conceptually, it's right. And as you can see, I bonded these 22 years ago with the 3-bottle system, which is all bond, and they're still okay. And I would recommend you not to change your way of working because a company says you have to change. If something works in your hands, why would you change? That makes no sense for me. Bonding with the rubber dam, this is how patient is. We will wait 24 hours maximum because she's tired if you do upper lower like this. Next day we will go for the grafting. So we did the crown lengthening 1 day before. We prepped 2 days before. 2 days later veneers are ready. Bonding, and the 4th day we will do the connective tissue grafting. Lower jaw the same. It's monolithic. It's not feldspathic. So my question to you is, will you always get this from technicians if they have to layer it? I have no idea. Maybe you can answer afterwards. Occlusion, nice. And then we go for the surgery. Now, that's what I meant about sequencing differently today. If you understand what we are doing here, is we position the tooth where we want to have it as a final position, and all the surgery will be done accordingly. Because if you would place a provisional there, you would angle it in at the gingival probably to make it more easy or more comfortable for you. So again, root conditioning. Do you need chemical root conditioning or only mechanical? There are studies saying you don't need the chemical. Again, I'm using citric acid since 35 years. I'm still using it today. There's no way that I would do something else if what I'm doing 35 years is working very well. And we had a little issue at there, canine, and you need to be, I want to show it because your brain needs to be, let's say, you need to be adaptive to the situation. Adaptive means there's like a small difference between what you planned and what is happening now during the surgery. So there was like a little black spot, and the more I removed it with the burr, the more it became black. So you're removing it as if it was decay. What happens if you remove it as if it's decay? You get depth, and you get depth where you need a connective tissue graft. So if you want to have something looking nice, you will need to adapt the thickness of the graft to the depth of the probe there at the canine. Let me show you, you will understand immediately, because we videotaped everything. Incisions, there's schools like from Munich school where they say you have to tunnel. There's another school saying CAF, you have to do coronally advanced flaps, which is in Florence. Again, the same thing. Just do what you think is nice. I think you can tunnel up to 2.5 millimeter, no problem. But if you tunnel, you go full thickness first, and once you're 1 millimeter beyond the mucogingival, you stay close to the soft tissue, to the mucosa. So you're able to advance it, as you can see. So incisions are important. And then we take from the palate. Most of the time, sorry for the music. Most of the time we do it like this. You make the incision on the palate, you go with the burr. Why the burr? We did a study, and we compared it histologically. Peter Schubach did the histology, and basically, if you do with a burr and you shoot it dry, not wet, the tags of epithelium that are way deeper than you think they are pulled out, let's say. So better to do like this with a burr, and that's the study we did recently. Then comes the graft, and we all make errors, no? I made an error here because my graft is thinnest exactly where I need more thickness. And then you need to be adaptive, not only adaptive in your brain, but also in the skills. So we are slinging in the graft on both sides, okay? It's just, you need to be patient and do exactly as it should be. It's not so difficult. I think, for example, when I graduated in 82, Professor Van Steenbergen told me, listen, Eric, you need to be from a different planet to place an implant. And I said, okay, maybe yes, but if it's like a screw in the wall, so let me see. No, it's only 4 people in Belgium that can do it. So that's when I came to your office. And what I liked a lot was you made it look like simple. And if it looks simple, let's say simple, it should work. I sometimes think I have more difficulties to extract a second molar that is completely decayed than to place an implant, no? Sometimes. So everything is relative. So again, here we needed extra volume because my graft was thick. Am I going to remove the graft and do? No, we put a second layer. So we create the convexity of the root of the canine. But again, the only thing I'm doing is adapting the soft tissue levels to the planning of the case at the start. That's it. And there's three ways to do. Either you're able to crown lengthen, either you're able to graft and bring down, and if it's really too much, you need to think about orthodontic treatment, orthodontic extrusion. So we're placing the graft, and then we are suturing it. We just published an article on this type of suture. It's like a sling suture, like a trapezoidal sling suture. Can call it modified Allen, whatever. It's just you bring everything down and bend the flap around the existing tooth. So that's suturing, not so relevant here probably. And that's how the patient is now after 2-3 hours. And what did we do extra? Basically what I didn't tell you at the start, and on purpose, is that I grafted these two centrals 22 years ago. She had a recession on the centrals 22 years ago. And you could see it was very stable, and even the graft, sometimes there's like hyperplasia of the graft because it was not controlled by the prosthetic form. So sometimes what we do is this. If there's too much thickness, you see there's too much thickness there, exactly here. And you will see it in the mirror immediately. If there's thickness, the light cannot get there from this angle, so you get like a grayish zone. The only thing you see the thickness there, is take the burr again. It's the same thing as in the palate. Take the burr, plastic it down until you create the proper thickness. And that's again something we planned in advance. If you grafted, remember I grafted 22 years ago, then you crown lengthen, so you're in a thicker portion of the graft, the original graft, so you need to flatten it. And these details make the difference. And in the end of the day, the digital project allows me to look at these details before I start. It's not just random. Look before and after. It looks like if we did orthodontic treatment on the canine, it's completely different axis. It's not. It's the same tooth. Would you ever plan, if you would not do it digitally like there, would you ever plan the canine to be like this? No. You would just plan it more angled, which makes it look weird. So the lesson is adapt and go from there to the guided prep, to the guided soft tissue grafting. How is it guided? It's guided by prosthetic form. And again, it will heal much better against this very, very nice fit between the crown and the prep, and with the material which is porcelain, much, much better. 6 weeks post-op, 6 weeks post-op. And then a little bit later, it's monolithic materials, but it's mainly, what is it mainly? It's planning, no? It's just a planning. All the rest became simple afterwards. Okay, before and after, we turned this a difficult, sorry, some of the patients really don't want to face there, so I'm not gonna, I had a friend who was sued because they saw him, one patient saw her face somewhere in US, paid 800,000 euro, sued for this, so I don't want to get this. If you want to learn more, we've published a book with Quintessence recently, so if you want to have some of these things, you can look there. Now, let's go full implant arch. And again, it's completely different than what we were doing before. Normally, if I have more time, I would show you what we were doing before and then what we are doing today. With implants, very simple. Before, many times, 40 years, 35 years ago, we were extracting teeth, placing a removable prosthesis, healing abutments eventually afterwards, and then we start to rebuild everything. But we forgot that wherever we had the anatomy of the soft tissue, it would be easier to preserve than to rebuild. So again, two things I want to show you is singular design. Singular design is the design that you just saw, but all of these tooth forms in SmileCloud, they have 1 millimeter or 1.5 millimeter beyond the cemento-enamel junction. And these were taken from CBCT combined with STL. So remember, singular design is a unique design of a tooth. We all have unique properties. It's biometric properties. The second thing is reverse grafting. What we did before is we extract, we place the implants, and then eventually we start the graft together or later on. Why don't we think differently and just bring the prosthetic form in and try to keep the tissue in place? So grafting without the same result without the grafting. Let me try to explain you with a case. First, singular design. We published in 2016 in QDT. I always saw my Brazilian technicians taking the model, and if it was a single tooth, they were just cutting the adjacent single central to have a look at the form of the root of the adjacent central, and then they copied it, flipped it around and copied. Then at a certain point we thought, why don't we just, if we need to extract the tooth, take an impression, a silicone impression, extract the tooth, put the tooth back into the impression, make a gingival mask, pour the model, and that's it. And from day one you have the form guiding the whole treatment. That's basically what we did. And today now this is relevant, I think. You see you have the crown of the tooth, and then you have 1.5 millimeter or 1 millimeter beyond the crown of the tooth. Let me show you this. Is it necessary to place 4 implants? No, not at all. But we asked the patient if we could do, because we wanted to show the potential of singular design in a flat or even negative concave ridge. I think what is the shift the last 10, 15 years is there's less grafting and more tooth form. And before was more grafting and less tooth form. So let me show you where we started this case. This case is this. It's edentulous since a long time, and the last thing she lost was the canine. Okay, so it's flat and even concavity canine level. Today what I'm doing a lot is make my incision, nothing new. It's incision more buccal. If you have a guide, you punch the palatal part, the half here. You leave this intact because most of the blood supply comes from the palate, not from the buccal side. And then start to reshape the bone a little bit according to what? According to the plan again. You have the forms, you have the 3D position, and the whole treatment is adapted to the form. So then you go and look at, this is the final bridge, but look where we were at the start. I did a very small connective tissue graft only on the canine, and these forms, we will keep them from day 1 to the last day. So you have a provisional bridge going in after 1 day. You have the final bridge, which is a copy of the provisional after 8 to 10 weeks, that's it. And the tissue is guided by the prosthetic forms, the pros forms. Why are these implants a little bit more distal? Because what we saw is that if you want the zenith to be a little bit distal, your implant position lead also to be a little bit more distal, for a central especially. If you have the central implant more mesial, it's very difficult to create a zenith prosthetically on the distal aspect. The same on the other side of the patient. Look now, very small graft, 1 day post-op. What is it? It's just prosthetic form. From a flat ridge, you create this. It's prosthetics. Today, our implant surgeries are more prosthetically guided. And whatever we create is kept in place by the prosthetic form. Now let's go to full arch. Same thing, think singular form and then think reverse grafting. So what is the challenge in most of these cases? Emergence angles, papilla height. If I'm talking FP1, I don't know if everybody knows you have FP1, FP2, FP3. FP1 is pure white. FP2 is a little bit of pink and white, mostly pink papilla. FP3 is a lot of pink and a lot of white. I simplify things, but I like when it's simple. So these are the issues. So let me go to this patient, which is a full arch patient. And sometimes these patients, they come to you for a very specific thing, and suddenly you're trying to convince them to treat them since a long time, and one little problem gives them the click in the mind where they say, okay, you go ahead. But then if I have a patient like this where there is a lot of decay, and especially root decay, I'm a little bit more cautious. I'm cautious for 2 things. First of all, cautious for root decay. And the second thing is I'm cautious with implants because they're not eternal. I can tell you they're not eternal. So today, after 45 years, I try to save more teeth than I was doing 20 years ago. That's my lesson in dental life. Anyway, this is the patient. So now I ask you, what are you going to do? Are you going to extract these implants immediately? What is your plan? If you place implants immediately freehand, okay, you're going to place them palatal, you're eventually going to graft in certain zones or certain spots, but what is your plan? How deep are you going to place them? What is your future tooth position? Difficult. And if you look at the face, these periodontally terminal teeth, they are flaring. It's like a class 2 a little bit now. And the minimum of the minimum is to have, this is like a 3D view. CBCT is the minimum. But what helps? It helps you a little bit. But what really helps you is to have a prosthetic plan. And again, you will see it's like with the other patient, the previous patient. The first thing in SmileCloud is I create data. I place my data in the file of the patient. And the data for these kind of cases, very simple. The CBCT, the face pictures, and the intraoral pictures. And the STL or PLY, your digital file. That's it. The next thing is I create my team. So I invite Peter, or I invite my technician, and all of them, I invite the orthodontist, I ask him, how long will it take you to bring the teeth back, intruding and bringing back eventually? They have immediate access to data, the same data. What was the problem before? I was sending to a WeTransfer to the orthodontist and then a Dropbox to this one, and it's confusing. So it's better to have all the data in the same place, and access for the whole team in the same place. Then we start to do the 2D design, just like the patient before. And then this is your prosthetic workspace. You determine the incisal edge position, you determine where you want the gingiva to be or where you think the gingiva would be. What is important here? Realistically determining the papilla height after extraction and implant placement. We know we're going to lose a little bit. Some people show you cases where they keep everything, maybe once in a while you can, but not always. You need to be realistic in your projections. So look where we place the future teeth. And it's related to the face picture and to what you expect from a soft tissue point of view. Software selects tooth forms, and this is what we can show to the patient now. Can you do it with a mock-up? Very difficult. Very difficult, because in most of these cases they are flaring out, and you want them to go in and up, your final tooth forms. So this is nice to be able to show. I can just click. The yellow ones are the tooth proportions that the algorithm thinks are the best in the frame. The papilla height on both sides, incisal edge position, and gingival sculpture. Start to segment, and this is important. This is relevant because if now, for a guided placement with a surgical guide, you want to place your implant, the best is not to follow completely the route. No, the best is to go somewhere where you can get anchorage. The next thing is today we are planning much more prosthetically, which means with the multi-unit on the implant already in the software of the planning. Why? Because most multi-units are wider than your implant. You can have your implants positioned 3 millimeters separated from each other. Then you place the multi-unit and only 2.5 millimeters left, and you have a problem. So that's important to plan with the prosthetic component on top already. So now I can visualize. Again, we stack the data, and you can see the red one is my projection of where the tooth form and the position should be. And the brown one is the old existing situation. We do lower, upper. And we will extract the teeth, place the implants with the guide, according to the red forms, take a digital impression, and the next day we will have a PMMA ready, screw it in, that's it. Okay? So the possibilities are huge. Now what is important, what is this reverse grafting thing? Maybe some of the it's not, nothing is 100%. I mean, some of the sites you will graft eventually, especially the edentulous ones. Some of the grafts you want to compensate, some not, depending what you want to do. This is the original tooth form. Look where the red form is. It's inside of the alveolus, supporting the soft tissue. I think the soft tissue support, like you saw in the singular design case, is important. Is the most important thing. And then after, it's up to you to decide which cases you want to graft. Nothing new. There's a study from Uli Grunder from many years ago where he placed 24 immediate implants, a few without grafting, a few with grafting. He lost volume when you didn't graft, and he stabilized everything if he grafted. But maybe they were not thinking about full arch with positioning and trying to support existing soft tissue. The implant distribution. What we know today is that we had quite a lot of zirconia full arch break, unfortunately. Maybe you have to tell me how you do and you don't break. Some people I ask and they say 100% success. We don't. So then we started to think, okay, if I need to redo, and they mostly break in the middle. Then we started to think, how can we solve it? Segment your pros. So in most of these cases, we will have 4 bridges, so one bridge here, one bridge there, central to canine, premolar to molar. It means you're placing more implants, so not necessarily charging more to the patient. Doesn't matter, no, if my implant costs 180 euro on a budget of 30,000 or 40,000 euro, it doesn't matter. So you make your life easy. If something happens, the precision of a 3-unit on 2 implants is much higher than a full arch on 6 implants or on 4 implants. So segmentation is one of the solutions. I'm not saying it's the only solution. And even for these cases, we make a guide in Exocad where we remove soft tissue. We sculpt the soft tissue before extraction, because once you extract, you lose all reference. So you crown lengthen before extraction. And then we go, that's what we did here. Then we go for implant placement. In this case, we placed BLX implants. What is more important than do it in a guided way, and this we did, I don't know if you heard about STAR complex, but not complex, concept. Save 3 acceptable routes. If you can save 3 teeth to position your guide, then probably you're more precise. So that's what we did. We placed the implants, but what is more relevant, or even a little bit more relevant, is look what happens in the posterior. Was an edentulous site, but if you align and you adjust the speaker ideally like in the red design, in many of these cases you need to reshape the bone. Many. Because you need to adjust prosthetically. Many of these patients, they're missing lower molars, the extrusion of the upper molars, bone comes down, need to reshape. What is the problem here? The problem is that we had many cases where we didn't really see in advance, and today we look at this detail really a lot because it forces you in many cases to do a sinus lift 6 months before you do the implant placement. Otherwise, you're left with 2-3 millimeters sometimes. Grafting only where it's necessary. Look at what we did. The crown lengthening guide has also these premolars, and you relate the position of your multi-unit, not your implant, your multi-unit platform to the prosthetic design, and only grafting in the lateral. So this is what we have the day of the surgery. Then the strategy of impression taking is nicer if you have 1 tooth or 2 teeth, because the scanner will recognize more easily. Final bridge the day after the surgery, not final, PMMA bridge the day after the surgery. And this is important also. At a certain point, we didn't understand why in our PMMA we were losing so much, sometimes a lot of papilla height. And what happened is we started to compare the output of the PMMA with the design we made. The design is green. The brown is your PMMA. Your machine, and especially in lateral incisor, the machine can never mill this V, the space for your papilla, as you designed it on the software. So your technician will need to help a little bit. So sometimes, look, sometimes this is killing your triangle. And it's nothing to do with the surgery, it's just prosthetics. And again, everything is related to prosthetic design. This is what I was explaining. If you are planning your implants and you think I have enough space in between, think about your multi-units. And many companies should make smaller multi-units. Many. Like they should make smaller healing abutments if you want to use it. So this is the healing after a few weeks with the PMMA. And then if you want, Either now you go for the final or you go for another PMMA if you want to change some details. What does it cost a PMMA? What does it cost a PMMA per unit in Germany? 100? Okay. Okay, that's not cheap. No, like if you ask in Bulgaria or Romania, it's like 40 euro. Then I would say I have the cost of the new PMMA and my tie bases. Again, related to the final budget is very, very small. So if you want, look what happened. We crown lengthened, we placed the implants, and still we could do better probably if it comes to gingival design for the central and this lateral. It's just a detail. How do you manage? There's two ways. Either you have the surgical guide again, go with the electrosurge. What is the problem basically? The issue is that your support prosthetically is not angled perfectly in this Z axis, like this. So what can you do? You just change now, make a new one, position the central out, position the central out, position the lateral out. It's just positioning. And I have these segmented now because it's after 10 weeks, and look what happens. That's where I want to have the soft tissue. And it's details, no? You want to have this, the canines are a little bit too bulky. Even when we brought them in, there's too much bulk up there and there's less bulk here. So we are doing two things, aligning this, the gingival part of the teeth, and just pushing. Look, we place the provisional again. And you will see some blanching of the tissue on the other side. And the blanching means there's more pressure, so I placed my crown in the Z-axis out with the gingival third. So the design of the zenith comes automatically, you see? It's automatic. And again, if there's too much pressure, what did we learn? And this is important. That one day I was in Florin's office in Timișoara, and this is an implant crown. There was a healing abutment. A healing abutment is round. The crown form is triangular, especially for a canine and an incisor. So what happens? It pushes on the tissue, no? Because they position it in the correct position with the gingival design exactly like it should be. Look at the papilla, what happens? Whatever you do on the buccal aspect has an impact on the interdental level of your soft tissue, which means there's circular fibers we know from Wenström. You have circular fibers. Too much pressure on the buccal, papilla goes up. Look where papilla goes. So then we said, okay, why don't we make in the zenith, exactly where is most pressure, we make a small incision, and this is 2 minutes later. Look where papilla is now. Just design. Prosthetic design again. What did we do 15 years, 20 years ago? Remove a little bit, and then 2 weeks later start to add a little bit, and then remove a little bit. Stupid. Just prosthetic design, and your soft tissue will flex according to the form. But it will only flex if you allow it to flex, which means if it's too much, make this little incision. Anyway, this is how it heals now. Papillas are okay, everything is okay. Then take the final impressions. There's multi-unit abutments everywhere, and these are the finals. What are these? Zirconia, 3-unit bridges, infiltrated. I think one of the best technicians now is in Timișoara, because whatever they get back, what I get back from them is a little different level than I was used to have. Basically, it's not as beautiful. It's 90% of what I had with the best technicians, but I have it in 100% of the cases. That's the issue. Normal dental technician, not a normal, I mean, any dental technician and all of us, we have like maximum 10 forms in our head that we like and that we will reproduce. Sometimes I recognize the work in the mouth of the patient and can correlate it to the dental technician that made it. The algorithm will never correlate because it's not the brain of the dental technician. It correlates it to the soft tissue anatomy and sculpture. Okay, so these are my final restorations. These are restorations in. And again, look, this is reverse grafting. We placed the tooth in, supporting the soft tissue, and this one looks better than the one I grafted. And before, 20 years ago, I thought it would always be better if I grafted. No, just positioning according to what you see on the CBCT. So if you want to look at CBCT and correlate tooth form, not only from the buccal but also the Z-axis, you need a CBCT. You need to be able to take a section in SmileCloud, for example, and see everything correlated, like the future form, the past form, the soft tissue and the bone, and then the implant position. How deep do you place your implants? The more I place them palatal, the deeper, of course, like 4 millimeters, 3 millimeter and a half. Some people like Linke Vickers say now 5, 6 millimeters. If it works in his hand, okay, no problem. But at least 3, 4 millimeter, I think. That's important. And what I like a lot is to look at cases. I scan the cases. And again, it's very valuable data to scan your patient again after a year. Have the assistant, so you have the follow-up of the case. This is going to be the future research, no? If you want to prove the method is working after 10, 15 years, this will be. So I think that's why the future looks bright, and we were able, basically what happened is we had the concepts that we had already 30, 40 years ago from people like Patalon, from Dr. Kirsch, from many other brilliant people. We did, and then now, 10, 15 years ago, we started to implement these concepts into the digital world, but having people like Florin and many other young guys that I work with, implementing it in a very clever way that is usable in the daily clinical life. Digital dentistry is not just scanning, it's just implementing it and trying to improve your standard of care. What happened now? If I compare what I'm doing before and now, I'm much more predictable. I'm much more efficient, time efficient especially. With less of, let's say, if before I had 25% of the whole plan that I had to adapt because of soft tissue levels or this or that, now it's only 5%. So we have less redoing the case. If you want to see a little bit about digital dentistry, Florina's this masterclass is, I think all these young guys, and I really love to work with them, that kept me on working. I closed my office 2 years ago in Antwerp because I wanted to retire, but then I found it so nice to work with young people that have brilliant mind and making you evolve in a very positive way to something where I can implement my knowledge or my experience or whatever, and learning and absorbing from them how they look at cases and how they look their daily life much more predictable. So I hope I was able in 1 hour to explain you a little bit what we are doing since the last 5, 6, 7 years. I think for the young people a lot here, the future is really bright. And I wish, that's my I really wish that I was born a little bit later, because I think dentistry is completely different now. Is it mine? It's here. So I'm just in time. Thank you very much. Thank you.